Hey guys, Marshall with PhysioU, and I'm here with two physical therapy students, Chris and Cameron. And today at the teaching table, we're going to talk about subjective. We kind of tried to gather a bunch of information from students and figure out, what are some things that they struggle with, have questions with, as they start to lead into the classroom. And so we figured, why not start out with subjective? Right, so when we talk about subjective, most of the time in school we learn this template. Right? We learn all these questions we need to ask, and it becomes this tick, this checkbox, and it's great for learning that template to understand, hey, this is information I need to gather. However, when we get to the clinic, it doesn't always work as easily or efficient as that, right? Patients are no longer these black and white textbooks, right? They're very gray area, and throw in a little personality and throw in a little bit of other issues going on. It makes it a lot harder. So the goal today was, how do we take that checkbox, that list that you have, and how do we kind of make it more clinically relevant, right? So if we're talking about a subjective, there's really a couple of big purposes of it, right? And one of the biggest ones that often gets missed is just the building rapport, right? There's a lot of talk about this therapeutic alliance, and really it's how much does the patient trust you? How much does the patient even think that you can help them? And that really starts from the minute you call them in the waiting room. So your subjective, even though you're trying to gather information for you, it's really about creating this environment where they feel they can be honest, they can trust you, so then they actually can have a better opportunity to get better. Some of the other reasons we do a subjective, right, big picture, is just to be able to lead our objective. So we need to be able to understand what are some of these key hypotheses. Right? Sometimes that means just listening to them talk for 30 seconds. You don't have to ask a question. Right? They're telling you, it hurts right here in the front of my knee when I go downstairs. It's like, oh, that already tells me a lot. Sometimes they say, oh, my knee hurts. We have to ask more questions, right? But the idea is, can we develop hypotheses? The next one is we want to get some information that lets us know if we're on the right track. So if I see them for an eval and then the next visit, I want to know if they're better or they're worse. Am I on the right track? Help them think, hey, are you getting better or worse? And so we need to make sure our information is measurable. So if we have ads of, hey, it hurts when I walk. And I'm like, okay, great, it hurts when you walk. Next time they come in, right, hey, how's walking? Nah, it still hurts. Okay, it's the same. If we make it a little more measurable, we say, hey, it hurt with walking. How long can you walk till it bothers you? 10 minutes. How high does your pain get? I don't know, like a 4. Okay. Next time they come in, how's walking? Still hurts. Okay, well, how long were you able to walk till it hurt? Man, I walked about half hour yesterday, and it was like a 2 out of 10. Hey, that's significantly better. It lets us know we're at least on the right track. Another big focus of our subjective is to understand the patient's irritability. Right? If the patients are highly irritable and have a lot of acute pain, it means our objective is going to be drastically different versus the person has a low irritability and they're able to get away with a lot of things before it hurts. It means when I'm planning my objective, I can add some pretty intense provocative tests. And then lastly, kind of goes into this rapport building a little bit, is just understanding why are the patients there, right? How can we best help them? What are their goals? And sometimes I hear from students or interns in the clinic, when they ask that question, it's often received. It's not received very well by patients sometimes. Like, hey, what are your goals with physical therapy? The most common answer is to not have pain, right? But then you're taught in school, right? Pain can't be the goal. It has to be get back to something. So it's always this way of asking it while using all this information you already gathered. So you're like, hey, so obviously you want to be able to walk with less pain. You want to be able to go downstairs with less pain. Anything else that you kind of hope to get out of physical therapy, right? We're trying to touch base on what are their expectations. A way that I ask it sometimes when they're not quite sure is, if you didn't have pain, what would you be doing? Or what are you no longer doing because of your pain? And we kind of then work it backwards and say, oh, okay, so the goal is to get back to spin class, which you haven't really done in 3 months because you've been worried about your knee. Great. His goal was to not have pain, right? But we were able to kind of milk it out of him a little bit that, oh, it's really to, what are you going to do without pain? So that's kind of like the first just overview. Like, those are the questions that if you do a subjective, you should be able to answer those questions, be able to create a thing. Sometimes that takes 4 to 5 minutes, right? Sometimes it could take up to 15 minutes. Just realize once you've answered those things and you feel safe to move on, you don't need to continue to ask every question in the book. Right? Okay, so let's hear some questions from you guys. So you guys being third years, you've been in the clinic, a couple of different rotations. What are some of the questions or kind of difficulties that you've seen in the clinic with subjectives?
Yeah, so I'll go first. So one of the purposes you said was building rapport. And I find it really difficult when the patient comes to you and they don't even want to be there, or they feel like you can't fix them, or they feel like their physician is the only one that fixes them, except the physician sent them to you. So kind of sitting there and understanding, how am I supposed to build rapport with this person if they don't even want to sit here with me?
And it probably doesn't help when you introduce yourself as a student, right? Right off the bat, like, hey, I'm a student of physical therapy. Yeah, I'm sure that builds the rapport and trust in you right away. Yeah, that's a great question. There's still a lot of patients out there that don't even know what physical therapy is. So I think one of the first things is just kind of letting them know off the bat, like, hey, physical therapy, have you ever been here before? And if the answer is no, I've never been here before, they're more likely to not know why they're there or not want to be there. Versus the person that's been to physical therapy 3-4 times for an ankle sprain, they got better, they kind of understand the process. Those people tend to know why they're there. So I think that tends to be my first question is like, hey, you ever been to physical therapy before? And the answer is no. I'll give them a brief, like a little rundown. Okay, well, we're gonna sit down and talk for a couple of minutes about kind of your problem, right? And maybe it's not pain, just problem. And then we'll kind of go into an exam and figure out, we'll test some things to see how we can best help you. And it may lead in some exercises, it may lead in some hands-on, but we'll kind of work through this together. So it's very brief, just kind of settle them down that, hey, we're going to talk, then we're going to do some stuff, and we'll figure out a treatment together. And I think that helps with rapport when you kind of use those words like together versus I'm going to do this, which is normally the relationship in a physician and the thing like, hey, I'm going to the physician, they're going to tell me my diagnosis, they're going to give me the pills, or they're going to order me this. I think we're in a little unique situation where we can really try to use their perspective a little bit to kind of create stuff together to build that rapport. Another thing besides that, right, you asked them, they don't need to know why they're there. It's asking the question like, all right, so how can I best help you, right? How can I, physical therapist, how can I help you today? If they don't have pain, it's like maybe they have some other goal, right? Often we see patients with like CVAs or strokes who don't really have pain. It's like, oh, what are you trying to get back to? What would you like to be able to do? And it's like, oh, I want to be able to walk from the bedroom to the bathroom without using a walker or a cane. It's like, okay, we can definitely create a plan in an objective exam based on ambulation versus they don't have any pain, right? We don't need to do any provocative tests to reproduce the pain. That's what they're here for. So I think asking those questions early on, you've been to physical therapy before, if they haven't, a little tidbit, and also like, hey, how can I best help you? Versus starting right off the bat with, right, so where's your knee pain? How high is it? Let's get a little overview of what their concerns are. Good question.
Kind of going off of that, what if someone has been to physical therapy before, but they've had maybe a bad experience, and then you're kind of, as a student, you're kind of thinking, oh, this is going to be an uphill battle just to convince somebody to buy into this treatment that you want to provide this patient.
It's hard to change people's beliefs. Right? They've already made their mind up before. It's hard. So the idea is trying to listen to their story, right? So if I've heard that, hey, you've had a bad experience in the past, they already have this nocebo in their mind that this isn't going to help. Right? How can I make that nocebo a little bit more like a placebo is kind of the goal. And so it's just listening, active listening. Everybody likes to vent when they have a problem, right? Whether it's your mom or your girlfriend or your wife or your kids, right? It's kind of being able to, hey, let me just listen, gather facts. And then sometimes I apologize. Like, hey, I'm really sorry that happened. Nice thing is I'm glad you're here now. You're willing to give it a second shot. The fact that you walked through the door is already a good sign for you willing. So I kind of put a little bit of a good job to you that you're willing to take another step. So what we can do differently this time, right? So I'm already creating this environment of, hey, it won't be the same thing since that didn't work to their point. What we can do differently this time is we'll kind of work through an exam a little bit differently. We'll try to see if we can dig deep into why you're having this pain, and we'll figure out if there's something different that maybe was not seen the first time, or maybe your symptoms have changed since then, where we can help you a little bit more. What I don't want to do is throw that other therapist under the bus. Right? You never want to put down your profession. So you're not like, oh, they don't know what they were doing. They gave you all the wrong exercises. That's kind of the worst because patients already think that. They come in thinking like, oh, I had a really bad therapist. They didn't know what they were doing. So I try to spin it to be like, sometimes our issues, whether it's pain or whatever it may be, sometimes it's just not appropriate at that time, or it's harder to work that time. But as time goes on, right, things change, and now we can help you a little better, and now you're appropriate. Right? I think a frozen shoulder is a great example, right? If it's super irritable, super painful, it's in the freezing phase, and you're in there trying to stretch and mow, that patient's probably not going to be too happy. Probably not going to come back, and they may be the person that says, yeah, they weren't helpful at all, they made it worse, versus, let's say 5 months later, pain significantly less, and now it's just, it doesn't go. Same treatment, same therapist could probably be very helpful. So it's understanding where the patient is, and sometimes I use that example with patients too, so they understand it. Another question you guys have, or?
No, you kind of mentioned one about pain in terms of stroke. When someone comes in and they don't have pain, you're really helping them out in terms functionally. What about someone that used to have the knee pain, not in terms of a stroke, and then comes to you and they say, hey, well, today I have no pain. So how do you really measure that aggravating factor if today they're feeling great, today's a good day? What do you tend to do?
So first I would dig a little bit deeper to hey, how long have you not had your pain? Right? Are we like the auto park car show or whatever it is? The mechanic where you go in, hey man, my car's making this noise, and the day you bring it to the mechanic, it's not making the noise. You go home, it makes noise again, right? So it's kind of well, how long have you had it? Has it just been a day? Then we're going to treat it as if you're still having issues. If it's oh, I haven't had it for a month. Okay, all right. Well, what's the most amount of stress you've put on it at this moment? Like, hey, have you gone back to hiking? Have you gone back to jumping or running? What are the things you would have been doing before your knee pain? Have you tested it? And if the answer is no, I haven't tested, I've been worried. Okay, then our goal is going to be to, hey, let's put you through that. Let's put you through the ringer a little bit. I will do it safely. So whether A, I bring on your knee pain, and we figure out where you're at, or B, you get through all of it, at least I've decreased your fear, your anxiety, and we've trained you into functional stuff. I think a good example is our post-op ACLs, right? Hopefully by months 4, 5, 6, they're not really having much pain anymore. They have good range, the swelling's under control. What are we working on? Function, right? They're jumping on one leg, they're running, and they're working on keeping their knee in line and their trunk stuff. We're working on functional stuff to get back to skills, decrease risk. So even though their pain's gone, we can still return to play, return to sports performance for these patients. We treat it that way. So our subjective then would change very differently to be like, hey, what are you not back to? And if they are back to running, a really good clinical protocol is, all right, well, if 100% was before you hurt yourself, you were going, how hard are you going? Right? Because you often have these players who are back in the sport and they're back practicing, but I'm only pushing it 70%. Well, what's limiting you to the other 30? I'm just worried. Does your knee bother you? No. Okay. Well, let's work on that. Then we can put you through some stuff to decrease that worry.
Cool. Yeah. Another scenario that I've come across, and I remember in my first clinical rotation, is that patient who maybe is highly irritable, or they come in with multiple issues. I've knee pain, but also my hip hurts, and they're just kind of throwing a lot at you. And as a student, you kind of go, oh gosh, where do I even start? So how do you kind of make kind of a hierarchy of kind of picking the patient apart of, okay, we're going to start here. This is the information I need to gather, so that you kind of have a clean subjective that will lead to that objective.
Great question, and that's not even as a student. Oh man, it's clinicians like, oh man, where do we start? Yeah, that's the guy coming in that's had all these issues and finally made the point for the doctor, said, well, might as well take care of them all, right? maybe a little misunderstanding of what physical therapy is for that person. So I think there's two parts to the answer. One is, if they have multiple body parts, I want to know, are they related? So I may do a full body chart and be like, hey, your back pain, your knee pain, your foot pain, possibly that could be one diagnosis, right? That could be this radiating leg pain or stuff. So I do kind of get an idea of where their pains are. And also, if they do have multiple pains, that kind of tells me maybe this is more of a central processing problem, a more persistent pain than really just a tissue source mechanical issue. So I kind of do gather the information, and if I start to realize that, hey, these don't match, it's his shoulder and his left knee and then his right foot, we realize, hey, this isn't one tissue source area. Then at that point, I have an honest conversation with the patient. Okay, it sounds like you have a lot of things going on, right? And I want to hear all about them. And we want to help you as much as we can. However, based on how much time we have, I can help you the best if we really focus on one. And what I used to ask is, so which one which one brings on the most amount of pain? What do you think the answer I got back was?
All of them.
All of them. All. So now I've learned it's like, hey, which one limits you the most, right? Which one are you most concerned about? Which one bothers you? So instead of like pain, because never mind, everything may be the 9 or the 10. It's like, all right, so which one limits you the most? And ideally it's like oh, it's my knee. I have to go to work and I can't work because of my knee. Versus the shoulder, it's there all the time, but he doesn't need that for work maybe. So I try to like spin that question on. But again, I think it starts to have an honest answer of, hey, I hear you. You have lots of these things going on. We can address them all over time, but based on today, I can be most effective to help you if we prioritize. So will you help me prioritize? In the past, it might have been a little bit more of, I just kind of brush it away. He keeps talking about his shoulder, and I'm like, okay, well, with your knee pain, when do you get it? Well, my shoulder, it's like you kind of hear brush it away, and then if I had a tally mark, it's like, oh, they brought up their shoulder 8 times now. So eventually it's like, oh, you gotta listen. So I've learned over the years to say, hey, how do I get them to focus? Because I can't really move on and get good information quickly if they're all over the board. So, but again, it's a good question, very common, right? Very common in the clinic to have these multiple body parts stuff. So, perfect. Good question, guys. So, again, if we talk about the order of our subjective, on the other slide, we kind of talked about the big picture we should answer. Right? Sometimes I have a little bit of an order where I do want to start with body chart, because that helps with our diagnosis. It helps a little bit with irritability. Is there pain constant, always there? Right? Is it a burning, sharp shooting pain, or is it's just this dull ache that comes and goes? So right off the bat, I've identified, hey, they pointed to the anterior knee, and it's intermittent, and it's a dull ache. That tells me about irritability. That tells me a little bit about the diagnosis. So now when I'm moving on to their AGs, I've already have an idea of like what I should look for, what I'm going to ask them. But the most important AG, the most valuable AG, is when you can track consistently, it's reliable, and that they bring it up. So if they're telling you, hey, my knee hurts with stairs, I'm not going to be like, so when do you notice your knee pain? How's walking? How's sleeping? My first thing's like, hey, you mentioned stairs. I heard you. Tell me a little bit more. And he's like, oh, when I go upstairs. Okay, upstairs. How can I make that measurable? Is it your first step? Or is it after 5 steps, 10 steps? How many steps does it take? And then he may say, oh, it's by the end of the first flight. Okay, how high is your pain? Let's get a pain number. And then the idea is like, okay, if he only does stairs once a month, I'm going to see him 5 or 6 times maybe in that month. How do I know if he's getting any better? Right? How does he know? So it's good to find an AG that you can check often. So I'm like, oh, so when do you do stairs? It's like, oh, I have my job every day. Oh, okay. How many times a day you go on the flight of stairs? 8 or 9 times a day. Awesome. That's a really good AG. You're going to test your AG 8 or 9 times a day, so we'll know if we're on the right track. So we try to make sure that, hey, it's trackable. It helps with our reasoning. We know if we're on the right track. It's personal to them, right? It's very clean. The other guy may only have 2 steps at his house, and that's all he does twice a day. Great, that is your AG. I want to know that information because it's very specific to each person. Both have pain with stairs, but it's a different situation. Again, helps with the rapport building, but also helps you with your reasoning. Some of the other things we want to do besides AGs and EASes, or I guess the other purpose of AGs and EASes is besides getting trackable stuff, it does help us with a hypothesis, right? We talk about going down a stair, maybe they have some patellofemoral stuff, versus I've got like a moviegoer sign where I sit for a long time and I stand up, right? There's different AGs that have like key things, right? We think low back pain hurts when I sit, right? Hurts when I drive. We start to think of, oh, maybe it's dysphorogenic pain versus hurts when I stand and I'm 65 and it hurts when I walk. Maybe it's more stenotic related pain. So we can use those questions and AGs to help guide us. And then, right, lastly, we have, let's say they're telling you this information doesn't really fit a common diagnosis you're aware of, right? So you always have in the back of your mind, like, hey, you know what? Worst case scenario, what could this be? Right? So you have our red flags. Then we have yellow flags, which may be more of like the psychosocial stuff. So for example, the guy is not able to give me good AGs. It just hurts all the time. What makes it worse? I don't know, it's just there. I'm still working, I'm still walking, it's just there, it hurts, right? Okay, well I may start to switch my questions for when do you notice it to, well, what do you think is going on? Like, let's tap into what do you think is gonna make it better? Why do you think it hasn't gotten better? So I start to ask these belief questions to see what their thoughts are on their problem, because that may be what I end up addressing, right? One of these key phrase would be like, oh, it's their thought viruses, right? They think it possibly is cancer, right? Or they think it's a fracture. All right, well, I need to make sure that I turn that thought virus into something more positive, or at least negate that thought virus somehow. And if it's something I can't do, right? If they're like, no, I'm sure that it's a fracture. Now I say, well, we did a tuning fork, but nope, it's fracture. Maybe the best thing to do is say, hey, let's talk about getting imaging. Maybe you need to get an x-ray. Let's talk to your primary care provider, because that hopefully will then prove to them. Maybe I should ask him, well, what do you think it will take to prove to you that you don't have a fracture? Hopefully he would say an x-ray. And I'm like, all right. Hopefully he doesn't say an MRI. That would be a little harder to get someone to order that. So it's kind of understanding, do they need these yellow flag questions? Do they need the red flag questions? Meaning, hey, at night, how's sleeping at? Any undisturbed sleep? Any weight loss? Any type of fever, chills, like stuff like that. Any problem with bowel or bladder stuff? And kind of, the guy that has an ankle sprain 2 weeks ago when he was walking down a set of stairs, do I need to ask him about bowel, bladder? Do I need to ask him if he's just telling you my ankle hurts when I'm trying to walk and run? No. So each person doesn't get the whole list of red flag questions, but you should have that template of, hey, you should probably have like 30 red flag questions. Some for people with lower back pain, some for people with more mid-back pain, some for people with head pain or dizziness, right? Everybody has different precautionary questions. And how do we do that in an efficient manner, right? That's all this, I mean, we can't even get through talking about subjective in an efficient manner. So it's how can we try to say, let the patient talk, build rapport, and then gather stuff quickly. Right? And I say, there's two little tidbits that I use and that I kind of talk about when students come to the clinic or residents is we call it stacking questions. That we want to give them time to talk, but when we ask questions and they answer, how can I use their answer to ask the follow-up so they know exactly what I'm asking? When we practice on each other, and I say, hey, how long can you walk till it hurts? You know exactly what I'm looking for. A time, 10 minutes. And how high does it get? You know exactly what I'm looking for. 4. Patients don't know that. So I'm going to be like, hey, so you mentioned it hurts when you walk, right? So when you walk, how long can you walk till it starts to bother you? 7 minutes. When you walk 7 minutes, right, how high is your pain 0 to 10? So I always use their answer. And they say a little bit. What's a little bit? Oh, a few minutes. What's a few minutes? Right? I try to just be a quick response to keep their time. Once we kind of have them on the hook, it's then we try to reel them in with very quick responses, quick questions. And they kind of call that stacking questions, where it's like, hey, you just keep using their answer to get to the next level, and then you've kind of strung out 4 or 5 questions where you've been able to ask a bunch. And it kind of works a little quicker that way, which is nice. So I think that's kind of in a nutshell, right? Our subjective. Thanks for joining with us today, guys. Thank you, Cam. Thank you, Chris. Appreciate you guys. Make sure to follow us at either PhysioU.com or at any of our social media stuff for more content on educational stuff. Take care, guys.